I hope everybody can see the screen. And welcome to you all to The Power of Place and this session on social prescribing for children and young people. My name is Marcello Bertotti. I'm a reader in community health at University of East London, and I work for a research institute called Institute for Connected Communities, which I guess is pretty in line with what the day is about, this session is about. The social prescribing for young people is, just as a quick introduction, oops, apologies. So the aim of this session is the development of social prescribing for children and young people. I mean, as you know, there is there is a substantial interest in social prescribing in general for adults. The NHS has committed to the recruitment of more than 1,000 link workers, and starting in 2019, early 2019, and has now recruited more than 1,200 link workers across England. So social prescribing is is developing very rapidly and for adults. However, for children and young people is not yet at the same level, and there is growing interest and growing examples, growing models of social prescribing across England and beyond, specifically targeting young people. And so what this session is about is two things really. One is a look at the current evidence for social prescribing and for children and young people, and secondly, some examples, some practical examples of different models from different parts. So we'll have 4 speakers. One is me, which I will introduce social prescribing in general, just a brief introduction, and in particularly social prescribing for young people, which is slightly different than the model for adults. I will also look at the evaluation of social prescribing that we led with StreetGames. And then, because we're looking at the evidence, Dan Hayes from Anna Freud Center will explain about his review of social prescribing for children and young people, and then we'll have some examples, some practical examples of social prescribing from Daisy Robinson, who's a GP in Devon, in Cam Valley, and she will take us through their experience and very case studies basically. And finally, Delia Beck, who is works for Sport England, and again she will talk about strategy for social prescribing from Sport England, and also some examples. I will let them introduce themselves more later. In terms of the structure of the session, I'll please feel free to post questions in the chat, and we will monitor it. We will take, we'll have these 4 presentations, which will last for about 15 to 20 minutes each. And after each presentation, we will take a couple of questions, so that we don't kind of lose too much, we don't do it all at the end. And finally, yeah, we'll have also a Q&A session at the end, so you'll be able to ask questions at the end if you wish to. And we'll basically, the session will last for 1.5 hours in total, but we can be flexible, slightly flexible. If there are more questions, we can go slightly beyond the 1.5 hours, and let's see how it goes really. And finally, please put yourself on mute if you're not speaking. I'm sure you by now, after all this long period of COVID, you'll know about all of this already. Yeah, so I'll move on to talk about social prescribing then. But before I do that, why do we need social prescribing? And because of this, because of these sessions and the conference and the theme of the conference, the power of place, I decided to ask you all, why do we need social prescribing? And as a starting point, and one of the reasons for social prescribing for children and young people is, I mean, it comes through what factors contribute to our health. You know, you will see on your screen clinical care. So there's access and quality of care. So, for example, access to GP practices, access to hospitals. The second factor that contributes to our health is socioeconomic factors like education, employment, income, family and social support. So, health behaviors is the third factor. So diet, exercise, alcohol, smoking, and finally physical environment. So I will now share, come out and share another screen, which I will invite you to go on Slido, but you'll do it more quickly if I do this. You bear with me a second. Hopefully this will work. You should be able to see now a slide, a web page with a Slido link and a code for that link, 706358. And you can also look at the code, at the QR code, if you used to do it that way. So we have already 2 responses, as you can see on the top right. And you should see this question, what factors contribute to our health in order of importance. You have to answer in order of importance. You should see the list of 4 possible answers. So I'll give you, say, a minute or so to answer. And then we'll talk about the answers, and that is quite useful to put social prescribing into perspective, really. So I'll shut up now for a few minutes, for a minute, and I give you a chance to answer. I'll now reveal the answers. Bear with me. I'll have to close the poll first. So I'll lock the voting and show the results. So the majority of you said socioeconomic factors. Let's bear that in mind. How many? Oh, well, anyway, health behaviors, physical environment, and clinical care as the last one. Okay, let's bear that in mind. I'll have to reshare. Bear with me a second, please. Right. So and now let's move to the answer. Right. So this is actually one source of the answer, because there are different studies that have looked at this. So as you can see, well, most of you really are right. So socioeconomic factors is the most important. In fact, according to this study, it's 40%. So education, employment, income, basically where we live is really important, and of course our income level and so on, for our health. And then second is health behaviors, which most of you got right, in fact, yeah. And health behaviors like sexual activity and alcohol use and so on. Thirdly is people put physical environment, but actually is healthcare. Is very slightly cynical views of the impact of clinical care, but is actually it's still quite important, even though it's not the most important. So anyway, it's just an interesting exercise, isn't it, to understand what is important. And of course, social prescribing has an impact on, particularly on socioeconomic factors, or should have, because it's more holistic. So it is about health and social care. So it helps people with employment, with education, with income too, and family for children and young people in particular. And secondly, it has behaviors too, because it helps with and refers people and signposts them to alcohol and diet and exercise and so on. So social prescribing is really important for that. But I'll move on now to the evaluation we did. It's a 2 years evaluation we did in these 3 settings in collaboration with StreetGames. And this is Sheffield, Luton and Brighton. These 3 organizations have helped us to Sheffield Futures, Active Luton and YMCA Downslink in Brighton and Hove, helped us to collect the data and helped us with the whole evaluation. So thanks to them too. We conducted a health and social outcomes survey. So we looked at health outcomes over a 6-month period. And we collected data from 192 participants at baseline and about 77 at follow-up. We also did a process evaluation, which really was aimed to capture the experience of different stakeholders and look at how social prescribing works in these different settings. So we talked to GPs, NHS officials, voluntary sector, and we did some focus group with a focus group with link workers and 2 focus groups with young people. We use young people to do focus groups with young people, so young commissioners, so which was quite an interesting experience. And finally, we did an economic evaluation, which is really a social return on investment. So it's a form of cost benefit analysis. And we also looked at GP consultation rates and A&E admissions. And see how this change over time. So let's look at what is social prescribing for children and young people, at least in terms of the models we looked at in these 3 settings, which doesn't mean that is like this everywhere, but that's our experience really. We looked at the main reason for referral of young people, and primarily so people were referred for their emotional reasons, so about 40%. Then 18% were referred for social isolation and loneliness reasons, and then the lifestyle changes and physical health. So emotional was by far the most important. In terms of the profile, we had an age range between 11 and 25, so and the mean age was 16, so it's bang in the kind of teenage years, if you like. Gender was female primarily, but male, but also male was quite high. This is in a sense important in relation to adult social prescribing schemes, because in adult there is often about a 70% female the number is about 70% female, and so but it's a lot more balanced in terms of young people, so which is interesting as well. In terms of ethnicity, we had mainly white British, so about 74% were white British. It's important to bear in mind that this data comes primarily from Sheffield, because that was the site which provided most of the responses really. And also the other things to bear in mind is that the data was collected during the pandemic, so there are some skews in a sense, or some biases because of the pandemic. Next is the referral source. So these are the main referral sources. So another is if you look at main referral source was actually self-referral and family and friend. Primary care was just below, so GP practices 18%, and also school and colleges were also quite important. And then finally, there were referrals also from children services and from local authorities or county councils, adult and, from adult and social care. So from statutory services. This again is important because in the conventional social prescribing for adult scheme, the main referral source is often the GP rather than school or self-referrals. So that's an important part. So next is the fact that young people were referred from these sources to a link worker. That's what typically happens. And this is a photo of social prescribing in Hackney for adults. Unfortunately, I couldn't find one for children and young people. But anyway, it's just to give an idea. The session were flexible, about 4 or 5 sessions across the 3 settings, the 3 sites, about 6 minutes each, sometimes even longer. And they were face-to-face initially, but then because of COVID, they moved to mainly text messages, really, which was seen as second best, really, by respondents. Practical and emotional support is mainly what was on offer, but also, so for example, practical, I'm saying, accompanying young people to buses, taking them to activities. So it was quite in-depth support in most cases. It's also important to remind, to bear in mind that is holistic support. So it covers both health and social. So if somebody needed help with housing or employment, that would have been offered. Although in this particular evaluation, there was a small part of what was needed, really. And outreach, so I think all the, most link workers doing outreach, and we're literally going to young people's houses and talking to their parents, first of all. And that's the interesting part as well, because balancing the parents and the child's interest is quite an interesting part of a special part of this, of children and young people social prescribing. And also seen as a coordinating role primarily. So it would coordinate schools often with other services and help the young people to navigate all of that. And finally, there is the range of services, so sport, acting, singing, but also alcohol support, homeless support, career guidance, and so on. So these are the range of services that were offered by the, by the settings and the voluntary sector organizations involved. And so let's move to the next one. So I'll go through the very briefly through the key results of the evaluation. Personal and mental well-being improved over the 6 months period, although personal well-being is still below the national average, mental well-being improvement was statistically significant, which is quite an interesting result. Social capital remained, which is social support and trust, remained broadly the same, and physical activity increased. So see, this is where the key messages really. So mental well-being basically improved quite substantially. In terms of the process evaluation, I'll go through some of the strengths and weaknesses. One of the major strengths is that it filled gap in mental health provision. So the help provided by link workers was immediate, quite available, was seen as available by the respondents, by young people, and so was seen as important for that reason. And both those stepping down and stepping up for mental health support. And also the practical support was seen as very important to young people. And the challenges is really, some of these challenges are actually common to adults. So transport, because there was a little bit of budget for that, but not a huge budget. So so transport was sometimes a problem for young people. So reaching activities available was a problem. Location of session activities, as I said. And also they were expecting more information about what to expect from services sometimes, and link worker sessions, what was available to them in some instances. And also the voice of young people was one challenge. In a sense, young people wanted a bit more voice in what the services could be provided to them in the future. So conclusions, because I need to. So one of the things that came out very clearly is that it takes time to build the buy-in from referring sources. This is common to adult schemes, and it's important to really not to expect that GPs or schools engage immediately, but it takes a long work and from link workers in particular to build those bridges. And the role of link workers requires flexibility. So as I mentioned, it was 60 minutes in most cases, up to 80 minutes in some instances, no 15 minutes consultations, which is a real worry in the adult scheme. At the moment, there are some signs that commissioners are pushing local social prescribing link workers to have a very short consultations, which defies the point of having social prescribing in a sense. And capacity is an issue. So there was, as always, a big problem that was highlighted by the process evaluation, and is again a problem with social prescribing as a whole. Well, social prescribing is even more important in the post-pandemic world, but I'm sure that the other presenter will talk about it even in more detail. And finally is only early days in terms of the evidence for social prescribing for children and young people. And as Dan will talk about soon after me, so there is a need to build more evidence around this, both in terms of evaluation and other research on how social prescribing and link workers can work as best as possible, really, with young people. So I'll take some questions now, maybe for a minute, and a minute or two. If there are questions, I'm happy to respond. Otherwise, I will pass on to Dan for his review. Any question?
I can see a hand up, Marcello, from Lorna.
Yeah, please, Lorna, if you want to ask, or maybe you have thoughts rather than questions. That is also important.
Hi, Marcello, can you hear me okay?
Yeah, I can, yeah.
Thanks. It's really interesting and lots of great food for thought. I'm a commissioner. I work in North Yorkshire CCG. So this is kind of my first step into understanding this better for children and people. I think what I'm interested in is around sort of the funding and commissioning for this. How in those pilot sites, has this been funded or commissioned? And do you know that, or does anybody know that really?
Yeah, I mean, I know some of it. If I get stuck, maybe Paul Jarvis Beasley can come in from Street Games, because he was managing with Don Mitchell the old program. But yeah, in these sites was funded by the Department for Health and Social Care, which had the Wellbeing Fund, I think.
Okay.
Called, and it was few years ago. So it started in 2018, I think. Paul, correct me.
Yeah, it started in, that's correct. The money that in the first year it came from Department of Health, but it ran for 3 years, or just over 3 years, and progressively it was funded locally. So that was one of the conditions of the grant as well, that it was on a tapering arrangement, so that the proportion of the Department of Health grant dropped off while local commissioning came in, and that worked really well, because the first year we were able to prove the concept and demonstrate the value of it, and then locally the commissioners from Public Health and also the CCG got very interested. What we've also found as we've developed it further is that we've now got multi-commissioned, co-commissioned models around the country. So police and crime commissioners have come in, as well as children's services and education, because it's hitting so many different outcomes. And that's been a really successful model. And then we've also got from the other side, the innovative approaches to how to make the business case. So from the provider's point of view, they recognize that the costs of providing some of the activities for young people can be very varied and difficult to. So they've, in Cornwall, for example, they've created a collaborative that is saying we will do a single price referral, and we will undertake to fundraise any difference in that. So at least the commissioners then have a very clear idea of what the potential costs would be. But very happy to follow up that conversation, obviously, afterwards, if you want to contact.
Thanks, Paul. Yeah, that's really helpful. That might be useful if I have further questions. Thank you.
Sure.
We might be able to get one more question. If there is any more question to ask, somebody wants to ask.
There's one in the chat, Marcello, from Susie. Says, I was just wondering if you know if the projects are continuing after the funding finished.
Shall I take that one as well? Yes, not only continuing, not only survived, but thriving. So what's happened, when Marcello was talking, he was talking quite, referencing the fact that adult social prescribing was quite well established and in advance of youth social prescribing. What we found in the areas where those projects started is they've now come together. So in Sheffield, for example, where they started with one youth link worker funded through the project, they've now got a team of 6, because the local commissioners, as we were hearing from Lorna, have said, okay, well, we've got some money for adult social prescribing, but actually we want to give it to you to extend the youth social prescribing program. So yeah, not only have they started up and continued, but they're actually grown as a result of the initial work. But again, we can provide more detail on that.
Okay. So I guess I'll can you? Yeah, you can hear me. I guess I'll pass to I'll invite Daniel Hayes to do his presentation now. Over to you, Daniel.
Thanks, Marcello. I'll just take control of the screen. Can you see that? Perfect. Afternoon, everyone. My name's Dan Hayes, and you okay, Marcello? Have you frozen? Yeah, okay. Can someone else say something? Marcello looks like
yeah, you're fine, Dan. I think it's just Marcello's frozen.
Okay, I wasn't 100% sure. Cheers. Good afternoon, everyone. My name's Dan Hayes. I'm a research fellow at the Evidence-Based Practice Unit, which is part of University College London and the Anna Freud National Centre for Children and Families. Most of my research is based in communities to look at mental health and well-being. And that's kind of both school-based and other community approaches. And previous to this, a lot of my work was in empowerment and shared decision-making, and how this linked with the community, which is how I fell into the social prescribing arena, and then subsequently made contact with Marcello and Paul. My first piece of work with Marcello and Paul was to actually do a review on social prescribing for children and young people in terms of mental health and well-being and what the evidence says to date. They're very helpful in facilitating networks to provide feedback. And today I'm going to outline a bit of that and the future work that we are undertaking at the moment. So I won't dwell on this too much because I know Marcello has based on this, but in terms of social prescribing, what we are referring to is non-medical community or social activities to help people manage or prevent illness and improve their mental health and well-being. This can be anything from going to the library to gardening to kind of surf lessons and everything in between. It's very varied and heterogeneous, which makes it difficult to study, but also quite interesting. In terms of the approaches that underpin it, it's very much a biopsychosocial cultural approach to mental health and well-being, if you're looking at it through that lens. And that means that there's acknowledgement, which Marcello outlined, regarding the kind of social cultural determinants of health, as opposed to like the purely more medical models, which is like more drug and genetic based. And Michael Marmot's done a lot of work on this, which is interesting to read up on if you have time. And as outlined, it's more established in adult populations where there have been reviews done. And for, I think Beck was a recent example of that. And they showed that social prescribing did help improve aspects such as anxiety and well-being. And the most common approach to, but not the only approach to social prescribing is the link worker model. And this is kind of a primary care approach where you've got a primary care individual such as a GP who refers on to a link worker, and then the link worker facilitates that social prescribing approach. And despite the widespread rollout and commitment to social prescribing, evidence at times, particularly with regards to effectiveness, remains patchy overall. So really what we wanted to look at is how this is affected by young people and child populations. And just before I go on to talk about the review a tiny bit more, just wanted to touch on the referral routes for social prescribing. So Karen Husk, who's based down in Plymouth, has done some interesting work looking at different referral routes. And this can be, for example, the direct referral route from a GP straight to the activity, as opposed to other link worker models, such as Link 3, where the link worker facilitates the activity in between. And what was found in the review was that obviously social prescribing is not a single intervention, but a series of pathways and relationships. But what the review really found was the role of the link worker is kind of key in stopping these relationships being disrupted. Without the link worker, it doesn't tend to focus as well. And whilst this is adult and primarily physical health based, adult and primary care based, we need to think about how this translates through to young person populations, and if other routes may be equally as applicable to young people, such as through schools. So as outlined, we wanted to conduct a systematic review. We spent quite a lot of time defining the search terms, trying to make sure that we captured the literature. So we started it in roughly March, April of 2019 and concluded it towards the end of that year, so December. And as outlined, what we really wanted to do was look at the evidence base and the impact of social prescribing on mental health and well-being for young people. Whilst we've outlined it as quite broad, what we really wanted to look at was social prescribing through the role of the link worker, partially because of the previous slide regarding what Karen found in terms of the consistency, but also this is where some of the kind of NHS England and Public Health England, etc., are concentrating their efforts in rolling it out for young people at the moment. We wanted to include a wide range of literature, so this included both kind of academic journals and academic papers, but also grey literature, so stuff that may be found kind of in reports and not on published websites, but still are accessible. We also linked with organisations that we knew were interested or facilitating social prescribing, one being the Social Prescribing Youth Network, but also Head Start partnerships, which are school-based program throughout the country, as well as the Child Outcomes Research Consortium. We searched various databases, which we knew would probably be the focus of kind of the academic literature, and also with an information specialist managed to pull out some other records that we thought might be relevant in the grey literature. So overall, we identified 1,307 records. Unfortunately, after a lot of searching and a lot of time being put into this and a lot of contact with organisations, it transpired that none of the none of the records that we searched, both in terms of academic and non-academic literature, met the inclusion criteria at that time. So basically, whilst there was a lot of social prescribing potentially going on, a lot of it at the time didn't include a link worker, or there was work ongoing, which we were aware of kind of happening in patches throughout England, but at that time hadn't been published. An example of that is Marcello's work, which is outlined previously. And as a result, at that time, given the paucity of evidence, we couldn't really draw any conclusions about the role of social prescribing to improve mental health and well-being for children and young people, which was semi-frustrating, to say the least. We then turned our thoughts to why there currently is a lack of research. Marcello touched on a couple of these originally. So one may be the complexities of translating social prescribing towards children and young people. Unlike adult settings, you've got another stakeholder involved, or at least one other stakeholder involved, and that is the parent. And we know from kind of more traditional psychological work that actually parents and young people disagree quite a lot on what is the causes of mental health and well-being, but also the options available to help and support you get better. And also other issues such as consent and capacity to consent from the young person's perspective. Another thought that we had was whether the primary care link worker model would be the right one in this setting, or whether other approaches could be better, such as through, or equivalent, such as through community hubs or through schools. And another point may be that kind of social prescribing just may be too new for this group and the evidence base hadn't developed as much yet. There were also questions that came up about what were the most appropriate measures to use with regards to social prescribing, and also the changing landscape of voluntary sector organisations popping up and then potentially running out of funding or closing down. And this was potentially highlighted or exacerbated due to the pandemic. We obviously had quite a lot of questions coming from that. And in in May last year, we submitted a funding call to the UKRI Research Network Emerging Minds. And this was myself, Marcello, Paul, and a few other people. And really what we wanted to do was begin to dig down into some of these questions. In particular, two were kind of popping up out at us. And this was also due to the fact that we knew social prescribing was happening and there were pockets of it happening around the country, but really wanted to find out more. So one was, we really wanted to understand what the best referral routes for social prescribing were for children and young people. Is it the primary care link worker model? Are there others? And what are the pros and cons of each? And the other questions that we had were, what were the current barriers to social prescribing for children and young people? This work is ongoing. I'll give you some preliminary findings from our research, but what we're doing is we're conducting 3 focus groups with young people. One of young people who have gone through the kind of more traditional or GP link worker primary care model. Another is looking through the other kind of referral routes, such as through schools. And then there's a more general one about young persons' opinions on the different models. So we had to get a range of views from different experiences that people have had, as well as more generally. And then in terms of the understanding the barriers to social prescribing, we want to interview, or we are interviewing, different stakeholders, around 10 from each group. And this includes young people, link workers, GPs, clinicians, and other organisations that are facilitating social prescribing. With regards to the question B, what we want to do is underpin this with something called the theoretical domains framework, and it's underpinned in behaviour change theory, and basically outlines that there's different factors that can affect barriers, and this can fall under 3 categories, such as capability, opportunity, or motivation, and there's sub-factors within each of those. And from that, you can then build up and make concrete recommendations and facilitate better intervention delivery through evidence-based practice. In terms of analysis, what we're doing is, for the first one, we're doing a thematic analysis. looking at kind of the pros and cons of the different frameworks. And then for the second one, we're looking at framework analysis to look at the barriers and what are the similarities and differences across them. And at the end of the year, we'll be producing different outputs, such as academic papers, a blog, and a mini conference presentation. In terms of initial findings, I will outline these are quite tentative, but these are some initial things that are coming out of the research, which will probably get refined in the next few weeks as we progress. So in terms of capability, individual, and particularly from a kind of clinician and link worker perspective, individuals are unsure about protocols, guidelines, and best practice when it comes to implementing social prescribing with children and young people. And they also have difficulties on knowing where to refer due to the current landscape in terms of both the pandemic, in terms of what's open, but also what might have closed or what might have changed since then, and whether they know it is actually a safe and appropriate service that they are referring to. In terms of opportunity, Marcello touched on this as well. Transport tends to be a particularly big issue, and getting places particularly outside of core working times. And this is particularly an issue with rural communities where things are much more sparsely placed. And then in terms of motivation, link workers in particular are outlining at the moment that they worry about the consequences for short-term funding of activities and what happens after, and they're unsure how best to engage caregivers in the process. And as outlined, once we've built up a comprehensive list, we'll be working with stakeholder groups to identify the most promising to facilitate social prescribing with children and young people. We are currently still looking to interview individuals, including young people. So if you are interested and are doing social prescribing at the moment, please do get in contact with us. You can either email Social Prescribing or you can contact me directly. And as outlined, findings will probably be out in October 2021. I didn't want to leave with just saying we don't know anything, so I wanted to just briefly touch on what the research evidence is coming out since then. I'm not going to go too much into this because Marcello has covered this already, but I think the key point from this slide that I wanted to cover was, whilst Marcello's work was open to all young people, there was a big chunk of young people, like a third, were referred to specifically for mental health and well-being. I think one of the most striking findings was only 6.8 of young people reported feelings of happiness or very high feelings of happiness. This compares to the UK average of 35%. And also the Schwemmwebs, which is a measure of well-being, was also lower. Despite this, as Marcello outlined, findings with regards to health and social outcomes were good, and they tended to improve. Another piece of work I'm aware of, which I think Susie's in this call actually, has been provided to me and been said I'm allowed to talk about, is the Tower Hamlet social prescribing work for children and families. This was specifically aimed at children and vulnerable children and young people who had autism or were waiting an autism assessment, or were medically vulnerable. There were around 625, it looks like, individuals that could take part. And during this time, and this was during the pandemic, a big chunk of this as well, link workers were contacting these groups of individuals and outlining what kind of social prescribing offers there were available. There were 161 that accepted social prescribing offers and given support with regards to social prescribing, and followed up at 4 weeks. This was a pilot study, and it's quite a long report, so I just wanted to pick out some of the highlighted successes of the programme and also some of the challenges, which I think echo some of the previous work that we've also discussed. Most families appreciated social prescribers calling them, particularly during the pandemic, and social prescribers felt that active cases where they were looking for families to be prescribed for social prescribing work was an excellent way of letting families know about what services were available, and they felt that the data recording systems and list they received was helpful in setting up kind of these social prescribing networks. In terms of challenges, some of the families hadn't had their autism assessment or diagnosis, so this limited some of the services where they could be prescribed to. And the word social sometimes was associated with social services, not social prescribing. Housing support tended to be the biggest need in both groups, and this was challenging to navigate with the social prescribers and complex to support families with. And obviously the pandemic impacted some of the services, and for some it was felt that the voice of the young person was left out. Yeah, and just to outline what we're doing next. So in terms of updated research, we are currently rerunning the review that we did 2 years ago, as we know that there is a rapidly changing landscape with regards to social prescribing and also a lot of interest. So we're currently running an updated review at the moment. And if you do have any work with a link worker involved and children and young people, please do get in contact with us and send us any information that you've got. And if it meets our inclusion criteria, we'll definitely include it and submit all of this round when ready. And just to flag as well, Marcello and I are working on a project more generally about the sustainability of community assets. And we are looking to interview people around factors that affect the sustainability of organisations which promote mental health and wellbeing. Many of you will be a part of this. So if you are interested, please do give us a bell as well, and we'd be happy to talk to you about it more. That's all from me. I'm happy to answer any questions. Sorry it's not more informative at this stage, but we hope to have a bit more research to share slightly later on in the year. Thank you.
Thank you, Dan. Well, I mean, the review, obviously somebody doesn't know whether they're going to find stuff when they start on the review. So I wouldn't, I mean, it's important to still do it, isn't it? And it's just good that you have done it. Yes, so maybe we can take a couple of questions if anybody wants to ask. I'm just looking at the chat and I think I can't see anything there. So if anybody wants to ask a question, please just unmute yourself and just go ahead and ask. Yeah.
Can I ask a question?
Yeah.
I'm just wondering if you were sort of looking to start this. I can see that on the website from the resource that you posted earlier, a lot of the projects seem to be funded by the Department of Health. And I'm just kind of wondering, like, how easy is it to, from the ground, kind of get the funding for this type of project? Does that make sense?
Do you want to have a go, Dan, or shall I?
I think that might be slightly out of my remit. I think you or Paul would be better placed to answer that in the first instance, not to pass the buck.
Yeah.
Yeah, go on, Paul.
Shall I? So yeah, very briefly, because I know we want to move on to the others, but so correct, the projects that we feature in the evaluation report that Marcello and Dan have both referred to are based on those 4 areas only that were originally set up with Department of Health funding. But as I was explaining earlier, that was only in the first year. In the second and third and fourth years, it became increasingly locally commissioned. By the 4th year, it was 100% locally commissioned. And since that time, we are aware of a large number of youth social prescribing programs that are setting up around the country. We're not in contact with them all, so I can't tell you exactly what all their funding models are, but certainly those that are set up in the last couple of years, when that Department of Health funding was a one-off grant, so it's not been available since. So they are all locally commissioned. Generally, what the picture we're getting is that they are co-commissioned by health commissioners, the CCG, local authorities, children's services, police and crime commissioners. So a whole range are getting together to put the money into a single pot, because it's hitting so many of the outcomes that Marcello and Dan have referred to. So they are locally funded, they're not grant dependent.
Okay, thank you.
I mean, I would add to that of course, the Department of Health is funding the primary care networks across the country to recruit link workers for adults. But there is, of course, the scope to have some of those link workers to specialize in supporting children and young people, which is something that might be in the future. I mean, I know, for example, one case in Newham, where there is a lot of consideration for this type of strategy, where some link workers for adults are actually being working for children and young people. So that would be, I guess, another way. I seen a question in the chat, but I think we are running. We're really. Carl, can you hold that questions, and we can ask you the QA at the end. So I would have to move on to Daisy now. Daisy, if you want to share your screen and do your presentation now. Daisy, as I said, is a GP in Devon, and she will talk about her experience with children and young people in Devon.
So hello everyone, I'm Daisy Robinson. I'm a GP in Columpton, which is in Devon, and I'm also social prescribing lead for Colne Valley Primary Care Network, which Marcello just mentioned, which is one of the new structures in primary care. And I'm going to talk to you about youth social prescribing, a primary care perspective. I'm not a researcher, I'm a jobbing GP with a passion for social prescribing, who's been working over the last 2 years to try and set it up for young people in my local area. So I'm going to try and cover so much today, and I apologise if I go over time, but I just want to really give you a flavour of the journey I've been on from a very practical point of view, and the sorts of people I've connected with to try and help this to happen locally. I guess the four main themes of my talk are going to be about, it's always about starting where you are. We've already had people ask about funding and commissioning and local arrangements. There was absolutely no funding for this when I started 2.5 years ago, 3 years ago now. So it's always about starting where you are. My experience has been it's often about the informal conversations that you have in your local area that can really generate support and momentum for things. And then once you do start to talk about resources and funding, being incredibly flexible about that and willing to adjust your expectations. And what I've tried to do locally is build up a really sort of place-based approach to wellbeing. I know I've got lots of different sorts of people in the audience, and I'm aware that you may all have been working in your communities to do this already. So I guess I'm just championing the idea that primary care could have a role in this as well, working with you. So just a little bit about me. I'm a GP, I trained in medicine. I became a GP because I wanted the doors to be open to everybody. I don't want to have referral criteria or thresholds. That's how that's what I love about being a doctor, really. I enjoy variety, I enjoy problem solving and getting to know people. And in medical school, I think I spent far too much time discovering all about illness, when actually I became a doctor and discovered that actually health was far more important than illness, and how we create health and how people cope and thrive with illness is far more important for a happy and healthy society. And as has already been touched on, it's often driven by far more than just the health that I provide, all the different socioeconomic factors that impact on it and enable people to live well. And this is why social prescribing has always interested me. And then the youth side, I went to a fascinating conference in 2016 about youth, adolescent healthcare and the development of young people of the mind. And I discovered that, for instance, vocabulary for young people develops much at a different rate, and the people coming to see me might have lots of things they wanted to say, but not able to say it in the 10 minutes that I had to give them. So that was something that I was always trying to think about how to solve, really. So I did actually just want to clarify what a primary care network is. Devon's broken up into 31 of these. We are a long, thin, sort of T-shaped one in the middle in rural Devon. We consist of 5 GP practices, and it's one of the ways in which funding has started to flow down into primary care and fund new models of care and new workforce, one of which is social prescribing. Our practice actually already had adult social prescribing well established back in 2008. We had a health facilitator. She piloted supporting people with diabetes. The Community Life Hub is a fantastic resource in our practice for older adults who want to use knitting or craft to get to know each other. And that was fantastic. But I was always aware that maybe there was something else we could do. We're quite a small rural town. We fall between two large urban centres, Exeter and Tiverton, and therefore sometimes miss out on some of the resource allocation and facilities. As I said, there's a focus on the 18+, and I was aware that there's a very high CAMS threshold and fragmented services and unmet need for young people who often came to see me in crisis. So 2.5 years ago, I was given a tiny little bit of funding. This was a session a month of my time by something called the Institute for Social Prescribing, set up by Michael Dixon and the South West Academic Health Science Network. It's actually come to a close now, but it was the idea that we would gather together people with ideas and give them support. So I just had a monthly meeting with a group of mentors really, to try and push this through and give me support for what I was doing. And the way that we started social prescribing in our primary care network was I invited everybody to lunch, and I spent money on some M&S sandwiches, and we all met together around the table in the practice, and I decided who needed to be there to discuss youth and well-being, and it was everybody really. It was the youth centre, the local VSO coordinator, school nurses, heads of the local primary schools, the town council came along, and the community police officers. As Paul has already said, there's so many outcomes that people share in terms of what they want to improve. So we started an open-ended conversation with no agenda really at the very, very beginning. This is our membership, which has grown over time. We've called ourselves the Colne Valley Youth Forum. The reason I'm giving you this background is actually this happened way before we ever employed a social prescribing link worker, and I think that's one of the reasons we were successful in doing so. I won't go into too much detail here, but we had a number of meetings where we established that there were lots of different issues locally. This is kind of asset-based, this is systems working, this is networking and working out where your shared goals might lie. Common challenges for young people were isolation, online danger, social media, sometimes feeling that the conversations they wanted to have weren't available where they wanted to have them, and there were some hard to reach groups that we might not be reaching. This is, again, I don't want to talk about this in too much detail, but we very early on went out to young people and asked them what they valued in their local town, and it was the library, it was the opportunity to volunteer, it was to go to youth clubs, and it was to have activities to do, and they very clearly told us that they wanted these things and more of them, especially outdoor, nature-based, non-competitive sport, which I know is key to much of what Street Games is about. So very early on, we started to build ideas and enthusiasm around this idea, and I did this purely through writing up posters and emailing them out to everybody. We wanted to come up with a tapestry of opportunities locally. Early ideas about a youth cafe haven't quite come off yet, but parent cafes in the primary school after school, volunteering opportunities for young people, essentially trying to build up a community offer for wellbeing. And one of the early conversations where we asked what will Columpton be like in 5 years' time, so this was a couple of years ago, everyone feels comfortable, everyone's more aware of how their actions affect others. There was discussion around bullying and how we can overcome that. Everyone knows where to seek help, increased sense of self-help and resilience, and actually being, building up the reputation and value of the town, a place where people want to come back to after university or college. So I was really excited a couple of years ago about this opportunity to create the first UK's future-friendly town, and we did. I've lost the slide. I was going to say before that that COVID hit. So we had the challenge of COVID, but I think I'll go on to this. So yes, UK's first friendly town. Before COVID hit, we come up with a charter that was to empower, support and connect young people across the system, improving access to a wide range of activities and creating opportunities for them to engage with their local community. And this again was just our collective vision, our collective idea for the town. There's my slide, and then COVID hit. So I think that stopped everybody in their tracks, and everyone can relate to that. And everything suddenly moved online. And suddenly it was actually we were able to have more meetings and have more conversations. So there were sort of pluses and minuses to that. I guess I just want to kind of clarify how the forum works. We're not funded, we're not commissioned, and we're not, we don't really have a governance structure at the moment. We just meet monthly or bi-monthly for an informal lunchtime chat to talk about, share information, resources, and for peer support really. And actually young people have been invited a number of times to come and join us, and we're looking for ways for them to do that in the future as well, post-COVID. The key thing, it brings health, voluntary sector, local authority and education together, so we all get a unique insight into the challenges and opportunities. Again, this is pre-link worker. Some of the projects we were involved in with through the lockdown were a lady who very kindly created a series of wellbeing videos for us using a little bit of community builder funding. And again, we produced this as a collaborative project to start to spread the word that this is what we were about. And she produced one for adults and one for children and families. We built up an online resource locally for, again, other people might have this and it might be funded very well, but I built this myself. Something for children and families and something for young people as well. Next step in the puzzle is how to really build a link worker into this system. So I had all this wonderful enthusiasm and people talking about how wonderful things could be. So on that basis, knowing that we were already funding 3 adult link workers, I went to the primary care network and made the case for funding a youth link worker. And how we would do that was we would go and work in partnership with our 2 Devon-based youth organisations who already provided youth support funded by the County Council and had already set up a scheme in our local city, Exeter. The pictures are of all the different patient organisations and groups that operate in all different surgeries, and the fact that we cross 2 counties, 3 local authorities and have 5 GP surgeries does make it complicated when you're trying to set up a unified service. So the youth link workers have now been recruited by our wonderful partners, Young Devon and Space, and we set up a service level agreement with them to run it as a pilot for 1 year. I think they're funded for a total of 24 hours a week. There's 2 of them, wonderful Jackie and Beth, who have been getting to know the local area, working out how to set up a referral pathway. We've been learning as we go, really. Basing it on a scheme that was running in Exeter, which had also been funded by primary care networks. The idea is that they'll meet with people one-to-one to provide the wellbeing support, listening to concerns and identifying opportunities in local community, overall aim of improving wellbeing and supporting positive changes. There's no closed door. Anyone can access the service, even if they're then signposted on elsewhere, and there's no exclusions. If you're under the care of, say, CAMS, you can still see people, see the link workers. We're at the stage of pretty much launching the service now, so I'm afraid I don't have any data about impact yet, but we're excited about what we can share in 12 months. We're going to be collecting data about referral, visa and activities, wellbeing schools. And the key thing is that these link workers are linked into the youth network that was already set up. There was a final step in the puzzle was how to launch the service, because the experience of Exeter had been slow uptake, and also limiting it to GP referrals only meant that it was a little bit limiting, because young people don't go to their GP, they go to their school and they go to their youth club. So I worked with the South West Academic Health Science Network to have run a stakeholder event. The key thing about this event was it brought together as many, I think there was about 50 people from across all the different sectors in our local population of about 36,000 to talk about the launch of the service and start to think about community wellbeing in this kind of asset building development kind of way. And again, this is quite new for primary care, this is quite new for GPs, and GPs hold the funding for some of the link workers. So it's really important, if you're going to try and set this up, to just speak to the GPs and try and make those connections and see if there's other enthusiasts who might want to do this with you. We asked what the issues were facing children and young people, and I guess this is just a background to why social prescribing is so needed. There's definitely rurality, lack of infrastructure, hidden deprivation, definitely housing, and the COVID impacts, as everyone is well aware of, have disproportionately affected some young people. We've got a particular issue with some migrant communities not accessing any kind of services at all in some areas of our primary care network. I asked people in the event to think about, essentially to use the event as a way of generating action. So what are local organisations doing now? What could they do in partnership, and what's not currently being addressed? I won't go into detail about what was produced. As you can imagine, it was a wonderful piece of work that I don't have time to do, but hopefully the youth link workers are going to be progressing some of those kind of ideas and into local community action in partnership with the community builders in the area. I think what I learned from doing an event like this is it's a great way to harness internal and external drivers in your local stakeholders. So asking people at the time how they're going to think or feel differently, everyone said they're now more aware, everyone felt more connected, everyone felt excited about the future, and then we're starting to create a positive narrative. And again, this is, I'm the person jumping up and down and being excited, and this was just a way to try and share that with other people as well. Asking people how we can ensure success, kind of gets that buy-in to make sure that they are behind you when you come along and say, right, I need some help or some specific resource now. Really providing space and involving young people and being consistent and linking with what current work is going on, because as people have already mentioned, in my area people were already connecting young people with activities. It just wasn't being done in a consistent way necessarily. So current ongoing projects are that we're trying to build up some youth volunteer case studies. A lot of difficulties around insurance with that, but one of our local GP patient support groups is helping us. And there's a local chef who wants to run cooking in the community virtual classes for families. We've been doing community wellbeing activities, and Active Devon have picked Mid Devon as a place to work with us to look at how social prescribing can reduce health inequalities. There's also lots of possibilities in the future. So there was an art competition as a collaborative project again between the local youth group and the surgery. We've really keen that we identify young carers, and I've got all my GP colleagues putting their thinking hats on and trying to refer people in who might be hidden behind people with kind of health needs. And there's going to be, again with the yoga theme, lots of yoga classes for primary and secondary teachers to try and support their wellbeing as well as the young people. Haven't got time to talk about everything, but our local community college has quite a growing number of pupils, quite high EHCPs and SEN needs, and we were at the very last minute, without knowing it, given a tiny little bit of funding to fund a link worker working in the school 1 day a week. So this is going to be happening alongside the adults, the child service run through the youth team, and again it's having to think on our feet and work out how they're going to run alongside each other when those conversations are ongoing. But actually what we've worked out is that young people might want to go to a school-based person or a community-based person, and actually you can't fix it. You can't say it has to be one or the other. I'll skip that slide because that's how that service is going to work, but I'm happy to share it afterwards. I've tried to build some community support for it through a website by inviting people to support the service and the youth forum in practical ways, offering work experience and volunteer placements, and sharing their information about what's going on locally. Again, I've hardly had time to do any of this, so some of this was done in a fit of enthusiasm a couple of months ago, but this, I guess, is the kind of thing that can be done relatively easily, cheaply and quickly to try and bring people together around the idea. So I hope that was okay as a whistle-stop tour. I'm going to just go through what works well and what works less well, because I think it's really important just to try and share the learning that I've had and we've all had over the last 2.5 years. I think
Daisy,
what works...
Sorry, Daisy, to interrupt. 2 minutes, yeah? Please.
Oh, fantastic.
Yeah,
I think I've got 2 minutes of talking to do, so
okay.
That's fantastic. What works well is multiple networks. So I just set up meetings with whoever you can and arrange to meet them regularly is all I will say, because from those conversations things start to happen. I know I might sound idealistic, but buying lunch from M&S really did seem to set things off in the right direction. We've now got multiple meetings that are happening, the youth, the link workers with the adults, the Colne Valley Forum, and a wider stakeholder group as for the launch event every 3 months. I think being creative and flexible is also really, really important, and sharing the offer widely. I've been to town council meetings, I've been to primary care network meetings, I've been to voluntary sector youth organisation meetings. I'll pop up anywhere really to talk about it, and I know that that enthusiasm is shared by the link workers who are now in post, and they will be able to sort of take some of that away and share it wider than I ever could. And seek out allies wherever you are. So even if you're working in an area that doesn't have anything like this at the moment, there'll be somebody who's interested in it, and they might be working in health, education, voluntary sector, police. You'd be surprised. So I think the key thing for me was just putting out an open invitation and seeing who turned up. I guess what doesn't work so well is pushing for early action. I was really keen to get this off the ground 2.5 years ago, and we're just getting going now. So sometimes it is a bit of a hard, long slog. I'm a bit of a perfectionist. I did want there to be cooking classes run after school that youth link workers would be able to refer people into. We don't have that yet. What we have are wellbeing videos that are on YouTube and people can access if they want to. But essentially having to just be aware that some things you try and do won't necessarily work. And what really doesn't work is holding on to where social prescribing belongs. It doesn't belong in health, it doesn't belong in the voluntary sector, it doesn't belong in education. It kind of cuts across all those sectors. And for it to be truly successful, I think you need to acknowledge that. Your funding might come from one pot, your champions might come from another pot, and your kind of people who are really good at comms and technology might come from another area entirely. So be willing to step outside what your comfort zone and try something different and build the case locally, because if you get a group of enthusiasts together, you can often share that success with people who are skeptical to begin with. So back to the original message, I guess, start where you are, start with informal conversations, be flexible and creative with your resources. It's systems thinking, really, place-based approaches to wellbeing, I think, are where the future is at. Thank you.
Thank you, Daisy.
Hi, everyone. It's great to be joining you today. And thanks very much to Street Games for the invitation to be part of this conversation. I'm Delia Beck, and I'm the lead for social prescribing at Sport England. But before I get to the work that we've been progressing at Sport England around social prescribing, I just want to zoom out a bit just to provide a bit of more of the strategic context for our work and talk about our new 10-year strategy, Uniting the Movement, which is our vision to transform lives and communities through sport and physical activity. Some of you may have caught some of this in an earlier session on, I think it was on Monday, by our chief exec, Tim Hollingsworth, but I'll draw out a bit more detail, particularly around how we want to work with partners, so large and small, national, local, who share our collective vision in ensuring everyone has the benefit or the opportunity to benefit from being active. Because we know, and I know many of you know very well, that opportunities to get involved in sport and physical activity can depend way too much on where you live and how much you earn. So we're looking to tackle this inequality really as a running thread through all of our work. Let's see, there we go. So I guess just to deliver on the ambition of our strategy, we're going to focus our time and our resources on 3 key objectives. The first one's around advocating for movement, sport, and physical activity, because investing our national lottery and exchequer money is a really important part of our role, but we're also much more than a funder. So we really want to continue to build and grow partnerships and really a common purpose across both government and our sector to join up policies, strategies, and approaches. And to keep building evidence that shows the links between the issues that we care about and the value of movement, sport, and physical activity as part of the solution. And a second objective is around joining forces on 5 big issues. And our consultation and conversations with a number of partners as a part of our strategy development identified 5 big issues that we need people to work together to address. And they're some of the biggest challenges and opportunities for creating an active nation over the next decade. And I'll run through them quickly on the next slide. But just before I do, I just want to touch on the final objective, which is around creating the catalyst for change. Because in order to achieve our goals, we need to create the right conditions for change. So we'll be focusing on developing effective investment models. So thinking about funding that's well-timed, it encourages collaboration and it reduces inequalities. Realizing the power of people and leadership, because people who spend their time helping others to be active, like many of you and those that you work with, are the greatest resource for us achieving the ambitions of this strategy. And also ensuring that we have high quality data, insight, and learning, because what we've learned from speakers already today, the key to collaborative action is having that shared understanding of the opportunities and the challenges. So I mentioned earlier the 5 big issues that we see as the biggest challenges or opportunities. And I'll briefly touch on them now, but I just want to zoom in on one of the big issues in particular, and that's around connecting with health and well-being, just to talk a little bit more about our work on social prescribing. And I guess one thing to flag from the start is that none of these big issues on the slide, nor the catalysts that I've just talked through, can be seen in isolation. They're completely integrated, they enable each other, they connect with each other, they cross over, and we really want to ensure that they aren't really worked on in isolation. So to provide a few examples of the big issues really in relation to the session today on social prescribing, we know that the impact of the pandemic has had on the sport and physical activity sector and much more widely. So as a part of our work on Recover and Reinvent, this is really about our collective recovery from the pandemic and reinventing as a vibrant sector that provides sport and physical activity that suits everyone. So within the context of social prescribing, this is really around how we ensure that there is a voluntary and community sector that can support individuals who are referred into community sport and activities locally. And this is one of our biggest challenges. Another big issue, which is relevant to the conversation today, is around connecting communities, because this is really around the vital role that sport and physical activity plays in making our communities a better place to live and bringing everyone together. And I know that this is really your bread and butter, working in places with communities to build on existing assets and the strengths of local people and places. So I'm not sure that there is an audience that better understands the realities around establishing these trusted local relationships than you joining the call today. But I'm sure you know that it could take a long time and it could be hard work. So for us, it's just important to recognize that as a really critical part of the process for how connecting into social prescribing and other local systems work. So what leadership is needed to drive this? How do we work to build the capability of local systems to enable this to happen? And another really relevant big issue for those joining the conversation today is around positive experiences for children and young people, as we will have an unrelenting focus on giving children and young people positive experiences to allow them to access physical activity and sport, so to give them the foundations for a long and healthy life. Because all of our evidence shows that the biggest factor motivating children and young people is enjoyment. And again, this is something you probably live and breathe every day. So how can we ensure that we have the places and the spaces in local communities which help encourage people to be active? So creating an active environment that promotes movement from age 8 through to age 80. And finally, just connecting with health and well-being. And this is where I'm going to zoom out a bit just to draw out what this big issue is in a little bit more detail. Whoop. Sorry, getting ahead of myself. Whoop. I think I lost the slide, but that's okay, I can just talk through it. I'm sure that many of you can see the knock-on effects of the pandemic on physical and mental health, which has disproportionately affected some groups. So this job has just gotten bigger and a little bit more important. So we think that creating a more meaningful connection around a shared health agenda will support our ambition by increasing activity levels, and in some cases even increase direct referrals into sport and physical activity organizations, because the nation's health is our biggest asset. And we know that sport and physical activity is invaluable for keeping children and adults as healthy as possible. But unfortunately, young people's well-being is at a 10-year low. And the number of children who are of a healthy weight is in decline. And this really matters because children living with being overweight or living with obesity are more likely to develop a health condition at a younger age. So there's just a significant unlocked potential if we can bring together the power of physical activity with others that also care about health. So this includes, the more obvious people and organizations working in and around health, like GPs and local health systems, but also the voluntary and community sector. And this will certainly play a role in tackling inequality, because many of these organizations reach or act as a trusted voice to those who have the poorest health or who are the least active. And this is really where our work on social prescribing originated, because we knew that in order to reach the audiences who were not moving very much at all, and as a result, not seeing the many benefits of an active life, that we probably weren't going to find them at a traditional sport club or at a leisure center in most cases. So the opportunity with social prescribing was to work with partners who had reached to and effective ways of engaging with those individuals who we wanted to support into activity. So I'm just going to take a step away from the strategy for a bit, because I just want to show this slide to illustrate the number and the types an individual could have contact with ahead of them joining activity in their local community. And we've already heard from speakers earlier around this initial referral route. It could be a GP or it could be a healthcare professional, or we know from the work from StreetGames has done already around social prescribing for young people, this is more likely to be through self-referral, through schools, through CAM services, as the trusted organizations will look different for different people. So we need to consider the wider local system here. And a lot of the work that we've been doing at Sport England in the health team is really thinking about how to create that seamless journey for the individual so that they are receiving consistent messages around the benefits of being active, but that they're also reinforced by different trusted people or organizations that they come into contact with. And as you can see on the slide, it isn't a clear linear path for social prescribing, but it can look really different in different local places, some with link workers, some with health coaches or care navigators, and others with community connectors. And because of this complexity, we've heard a lot of interest in learning more about social prescribing from our partners. So we've developed a vision for social prescribing, which really brings out the things that we care about and that we want to see as a part of our work in this space based on what we've heard from partners. Because we know that we need to have a high quality sport and physical activity offered that's person-centered, it's accessible, it's inclusive for everyone so that we can work to reduce the inequalities that we know exist in participation. So in order to do that, we need to work in partnership and in a collaborative way across sectors, which Daisy also highlighted, because we need to see that whole person, not just their interest in football, but their struggles with finances, the trouble they might be experiencing at home or in connecting with other people. And this really feeds into what we feel our role is in this area of work and our approach to delivering our ambitions around social prescribing. So how do we contribute to and inform the national dialogue and advocate for the role that physical activity can play as a part of a social prescribing offer? So building relationships from a national level through to a local level. We're working with the National Academy for Social Prescribing to help partners to develop resources, information, and support to really help them connect into opportunities locally. And a big role for us to play is in connecting the dots between what we know is already happening across the sector and brokering or fostering new partnerships or ways of collaborating. And another role that we play is really around channeling information, because there is so much happening across the country and it's really happening at pace. So we've recently appointed a team of 7 regional physical activity advisors whose remit is exclusively around physical activity and social prescribing. So we can start to capture learning around what partners are starting to do in this space and really start to understand the various challenges and opportunities. So the region with the National Academy to support the Thriving Communities program, pulling out some good practice examples, identifying the blockers and helping to facilitate connections between local health systems and physical activity sector partners. But this is just the start of the journey, and there's still a lot to learn around how we do this and what support resources and tools are needed to really facilitate those links locally, because we know that there will be wider system blockers which need to be addressed, but we need to listen to what's happening in order to best respond with support that is appropriate. And that could be, for example, just raising some of the challenges that might be experienced locally with national partners like NASP or NHS England. So I know we're running out of time, so I'm just going to wrap up the session with a little bit more information around our timelines for delivering Uniting the Movement. We've now published our implementation plan for 2021 to 2022, with the implementation plan for the next 3 years due out in December. And the first is a series of plans that will lay out more detail around where and how we'll focus to meet the challenges within the strategy. But I really just wanted to show the slide to highlight the period that we're in now around the implementation planning, because this is where we're starting to dig a bit deeper into the opportunities ahead of us, including social prescribing. There's so much interest from partners around this, and an interest in supporting young people through this approach is growing super quickly. So whilst we haven't focused exclusively on young people in our work to date, I just wanted to highlight that we're in a period now which allows us to plan for the future and respond in the best way to keep people moving across the life course. So we're really keen to build on the learning from partners like StreetGames and local delivery pilots and others who have been starting to test and explore opportunities around supporting youth social prescribing. So stay tuned, and thanks very much for listening.
Thank you very much, Delia. I know it's 1 o'clock, but if there are questions coming in for either Daisy or Delia, or indeed anybody else, welcome everybody to just unmute themselves and ask the question away, or post it in the chat. Yeah. I can see a question, yeah, from Carl earlier about minimum standards. I think that was kind of partially answered by Paul. I think there was so if Carl, if you need more detail or you want more information, just come in and ask away now.
Okay, thank you. Can you hear me okay?
Yep.
All right, brilliant. I'm from Hartlepool Sport in the sunny northeast. We've had a presentation from Paul a few months back, and we've already got a bid with the 3 primary care networks in the town to look at a social prescribing model. Our charity, the PFC Trust, has put a little bit of money in towards it for like a pot for paying for activities and things. The barriers we're reaching at the moment is the PCNs stepping out of their geographical area to work across the whole town. And also the fact that obviously young people are not getting referred through GPs. So the proposal that we've put in is be based in 3 of the youth centres across the town. I'm just wondering if there's any live experience or live projects that are running with a similar sort of community-based young person model that we could share with the PCNs to show that there's that proof of concept there.
Is there anybody in the panel here? I mean, Delia, Dan, Paul, Daisy, who wants to answer this question?
Don't know any specifically in youth centres, but there is some school-based ones that I could share if that's of any help. And I think Daisy knows a couple of school ones as well, but none in youth centres from my remit at the moment.
Daisy, do you want to come in and then I'll...
It was to say that we've tried to set our system up, Carl, so that it doesn't exclusively require a GP referral. And I was absolutely clear on that from the start. So, oh, sorry, I can hear an echo. I apologise. Paul, I'll come back.
Okay. Yeah, Carl, I know we've spoken before on this.
Oh,
that's great.
I'm okay now. Sorry.
Okay.
I'll just say, and we've got in our forum of people who sort of work with the link worker or work with me to try and promote the link worker service. We've got a local youth worker who provides youth clubs. So he's kind of building a personal relationship with the link workers. Hopefully the idea is that he would be able to funnel people towards them. And also the school, we've got funding for somebody to be in the school 1 day a week. And my vision was always that the link worker would never be based in the GP surgery. They might spend a day in the local library where they've got the ability for people who go to the youth club to come and see them, and a day in the school and a day in the surgery if that's where people want to see them. And referral routes absolutely being open to, you know, probably youth services in the community rather than self-referral or the public at the moment, but that's including school nurses, schools, youth work and GP. Yeah,
I think I know what you may be also trying to get at, Carl, is that why would a GP want to fund somebody who's, or potentially support somebody who's not in their practice? And what we found, I think the approach is exactly as Daisy described: get people around the table and it soon makes sense. So all of the link workers that we know about are all community based. They're either in school or community settings and doing outreach. None of them are actually based in a GP surgery, but they may be in post using money that is allocated to GPs via their primary care networks. But because that local conversation has taken place, exactly, someone's had lunch around the table with someone like Daisy and have understood that to reach young people, the best place to put that link worker is not in the GP surgery. And interestingly, what we have, and Daisy may have some reflections, with adults, one of the primary drivers for social prescribing is actually to reduce the demand on primary care on Daisy's time and others working with Daisy, because they're often, adults are coming for things that can't be fixed medically. With young people, it's often the other way around. Actually, we're finding that we want more young people to engage early on with primary care and feel comfortable about coming to their GP. So actually, the link worker can have that role as well by having that's one of the selling points for a GP, because they will know that the longer a young person takes to turn up at their door, sometimes the worse things become. So actually having that early engagement with young people, once they start being, you know, they're not being dragged along by their parents and they need to get there under their own steam. So there are some interesting differences, but as I say, all the link workers are community based that we know about, and it's resulted from a conversation, exactly as Daisy described, about what are our shared interests and outcomes here.
I think I would add to that also is about for the GP to so it's about what Daisy I think was saying earlier about creating health. So is the GP has to acknowledge the fact that actually we need to create health in order to prevent young people to get into the GP practice in the first place. So in a sense, is a self-interest of the GP, but it takes a much longer period to be done in a sense. Yeah. Any other point? I mean, if I can just summarize my thoughts here. One is that M&S sandwiches seems to have an impact, although we might want to extend that to other supermarkets. So and indeed linked to that is that co-production is important. Is co-production in terms of partnership working? Is co-production in terms of the relationship between the link worker and that young person, so that they both have a voice in a sense. Another thought is that no one size fits all seems to be, so that there are so many different models and it needs to be adapted to the local circumstances. And this is true for young people and true for adults as well. And finally, it's about social networks at the end of the day. I mean, it's about creating social networks or maintaining the social networks, especially with COVID and post-COVID. And so the social networks will help individuals, but will also help communities to grow and of course, social networks, social isolation is a major cause of mortality, as the same as smoking or obesity, from some studies that have been published. So preventing social isolation is key, and young people more and more are socially isolated or lonely. The two things might be different. I mean, and if I can just another thought is about the online, that and a lot of young people are more online than we ever are as older adults, and I think there needs to be something around that as well, around how social prescribing can help people to tackle some of the problems caused by online, by young people going online for too long. But sorry, just blah blah blah. Any other questions? No, I think we've gone over quite a bit, isn't it? 10 past 1. So I thank you very much for attending this session, and have a good day. And if you want to write to us individually, please, I think you have all the details on the chat. Thank you very much. Bye bye.